And now Dr. Crystal Aguh is coming up to talk about hair considerations in Black women. And I think that this is a really important, cultural competence is unbelievably important in the world in general, but we need to be better about it in medicine, and we're going to learn how to be better with this talk. Thank you.
Thank you. Those were really great images. So I'm hoping that the tone of this entire session is going to be positivity. And you guys are so brave for coming to a hair loss session, because hair loss is so hard and there are so few things that we can do to make things better. And so in my two talks today, I'm really going to try to give you pearls to improve your outcomes. There are really easy things that we can do for all of our patients. When I talk about hair care considerations in Black women, I'm primarily talking about curly hair, which we can see regardless of ethnic background. And additionally, I'm really talking about fragile hair, right, which we can create whether we are coloring our hair, we're using a lot of heat. And so a lot of these tips are helpful across the board whenever we see patients with damaged hair types. But I'm going to focus on this group just because tightly curled hair tends to be the most fragile. So just as some background, there is no chemical difference when we look at different hair types. The percentage of keratin, the types of keratin that form the hair shaft, that's really identical across all ethnic groups. Most of the differences that we see have to do with a couple of things. One, the curl pattern, and if you look at the bottom and see the elasticity, that's when you cut the hair shaft and look at it in cross-section. Straight hair will look curly in cross-section, will look circular in cross-section, and curly hair will look more oval. We also do see differences in growth rate and hair density. And one thing I try to really remind my patients who have really curly hair is that there are pros and cons to every hair type, just like there are pros and cons to every skin type, right? If you have fair skin, you are not going to get hyperpigmentation from routine trauma, but you're at increased risk of skin cancer. And the reverse is true, right? If you have brown skin, you have to deal with hyperpigmentation, but you're at lower risk for skin cancer. Same thing with hair. If you are evolving in a sub-Saharan African climate, you want your hair to do a few things. You want it to be low density so that the scalp cools very easily. You want it to grow upward, not downward, so hair is not covering your shoulders, because 10,000 years ago, when there were no styling tools present, if you're just trying to fend for your life, you do not want hair to grow past your shoulders. If you were trying to fend for your life in Miami, Florida, you don't want hair past your shoulders, right? And so if you are not styling and grooming your hair is designed to break off as easily as possible. That is an evolutionary advantage. Okay, 10,000 years ago with no styling tools in Northern Europe, it is an advantage to have high density hair that provides extra heat, that grows easily past your shoulders, even if you do nothing at all, okay? And so I just keep my patients aware of that. When you think about the hair, you can really think about it in two parts. The cuticle, that's responsible for the appearance of the hair, so anytime we're using conditioners or shampoos and that shine that we're trying to get, we're affecting the cuticle. When we are permanently changing the appearance of the hair, whether you are dyeing your hair from brown to blonde, or you want your hair to go from curly to straight, or you want it to go from straight to curly, you have to break the strong bonds in the cortex. Those are called disulfide bonds. So a lot of the practices that everyone, many of us women do, we're doing them through the same mechanism. So hair dye is very similar to chemical relaxer from a scientific perspective. The other thing to keep in mind is sebum. That's the natural product of the sebaceous glands. Sebum is a great protector of the hair. And if you have straight hair, sebum coats your hair very easily just from one swipe of a comb or brush. And because sebum attracts so much dirt, this is why people with straight hair feel inclined to wash their hair every day. But if you have curly hair, that sebum just gets trapped right at the very top of the hair shaft and has a difficult time making its way down every twist and curl, right, of that hair shaft. And because of that, if you have curly hair, you don't wash as often because you're not attracting as much dirt. It doesn't feel oily or greasy, but again, you don't have this natural protectant, so now it's easier to break. But remember, evolutionary advantage, right? That's very smart from an evolutionary perspective, but it changes a lot about how patients treat their hair. So what does that mean? If you put all of that together, these are scanning electron micrographs of the hair shaft. If you look at the left panel, A, C, and D, that's what happens to curly hair when you comb and brush it. This is not someone who's neglecting their hair. If you comb curly hair, it forms complex knots that break the hair shaft, and that breakage travels all the way up the entire length of the hair shaft. So that's how people can get breakage that breaks their hair off to their ears or to their scalp. And then if you look at the right, you see examples of different hair types when they're weathered. So when the hair grows longer, longer hair, regardless of your hair type, is weaker hair, right? That's why we trim off our ends. But when you look at curly hair types, we tend to see that the ends of the hair tend to be a little bit more ragged and increase the tendency for knots and breakage. And so when we see our patients with curly hair and we see that they have traction alopecia and they say, well, I have to braid my hair. And we're like, oh my God, like, how could you keep doing this to yourself? Just remember that styles that we see in curly hair are really trying to achieve one of two things. They're trying to eliminate the tendency to have to routinely groom the hair so they don't get that breakage that you see here, or they're trying to permanently straighten the hair so that sebum has an easier time coating it so that it doesn't break off as easily, okay? So we can pretty much put almost every hairstyling practice that we see among women with curly hair into these two buckets, really trying to avoid some of these kind of, very common disasters. So a lot of times people at this point of the talk will say, well, what do you recommend people do? Relaxer sounds terrible, right? Everyone should go natural. Well, regardless of what people choose, they're really trying to stay ideal, right? So if they're like, I'm not gonna use relaxer, they wanna look like this girl on the left. Very beautiful, full, high volume hair. And if they decide to relax their hair, they wanna look like the woman on the right. I really could care less. To me, both of these patients have very healthy hair. In reality, this is what patients look like in my clinic. On the right, they choose to relax their hair, and their hair's so broken, and it breaks off to the shoulders. Because if you relax your hair, you're gonna be able to get it to the shoulders, but you're not gonna be able to get it much longer than that if it's not being taken care of. And on the left, this is what we see in 2024. Most of our patients are actually natural, and when natural hair is not taken care of, it breaks off all the way to the scalp. And you guys can appreciate here on the scalp vertex, it's visible. A lot of these patients we're misdiagnosing as CCCA. Okay, so how do you take care of hair, whether it's natural or relaxed? I put a couple of differences at the top in bold there, but what you'll see is that the hair care approach is identical whether your hair is natural or relaxed. So that previous picture I showed where that lady had all that breakage in relaxed hair, I'd say that's our average hair breakage patient in 1994. And in 2024, she just turned to the lady on the left. It's the same person, right? Because they're doing the same thing. They're getting slightly different results, but still very unhealthy. So relaxers, as I mentioned, because you're permanently changing the appearance of the hair, it requires a highly alkaline chemical to break the disulfide bonds. Does anybody know what the alkaline chemical is for hair color? You can just shout it out. Because I see a little color in the audience. Okay, it's ammonia, okay? So with chemical relaxers, you use sodium hydroxide to break that bond. With hair color, you use ammonia to break that bond. But all that does is break the bond. So for the chemical relaxer, you straighten the hair manually, and then you stop that chemical reaction by applying an acidic neutralizing shampoo, and that's the end. For hair color, you break the bond first, then you have to kill the melanocytes. That's hydrogen peroxide. So usually when I ask people, what's the alkaline chemical? Everyone says hydrogen peroxide, which is acidic, right? But that's step 2. And then after you've killed off the melanocytes and your hair's like orange, then you can put color on top of that, right? So relaxer is a 1-step process. Dye is a 2-step process, okay? Wigs I wanted to talk about because this is super popular in 2024 for people to wear wigs. They look very natural. People can attach them in ways that allow them to stay in place for weeks. The huge downside is that they're so easy to apply and that if patients over-rely on them, they don't take care of their hair underneath anymore, right? I mean, it's just so easy to just plop on a wig, and so now we're seeing a lot of damage underneath the wig. And then additionally, a lot of our patients are using glue to adhere the wig in place. Sometimes patients may come into you and they say, I have hair loss. And you say, okay, can I take a look? And they say, oh, no, I can't remove this, but I have pictures, right? I make those patients come back. But you can imagine that with this adhesive, you can have an allergic contact dermatitis. And if you do, all it takes is a single use of this for people to have permanent scarring alopecia. And I've seen it happen, and it's really, really devastating. I did want to talk about sister locks and dreadlocks, another super common style. A lot of my patients who have sister locks in place, they think this is actually the safest type of dreadlock to install. You can see on the left, that's what it looks like in its ideal presentation. On the right is really the final appearance for everyone who has sister locks. For some people, it may take 1 or 2 years to get here. Others, it'll take 10 years. Again, you can imagine that this would often be diagnosed as maybe CCCA because of all of this central scalp thinning. This is actually traction alopecia, and this is what traction alopecia looks like with dreadlocks. So when we learn about traction alopecia from braids and weaves, it's that frontal hairline with fringe sign, but this is the exception. The upside is that if you treat this the right way, they'll improve, but only if the locks are gone. In my patients, I treat a lot of patients with CCCA. About 2/3 of those patients will have concomitant traction alopecia, usually because they're trying to cover up their central scalp hair loss. But I tell them, really end-stage advanced traction alopecia is much more disfiguring than CCCA. With CCCA, you can still put your hair in a ponytail, right? It's kind of like frontal fibrosing alopecia, very devastating because it's obvious to the casual observer, and it may require wig use early, right? So you may be, using a wig just to start in the beginning because you want to, and then you get to the point where you have to wear a wig. So this is how I and my clinic like to divide up traction alopecia. Stage 1 is really these young teenage girls. They put in a couple of styles, their hairline thins out, but if they take a break, everything comes back. This is the stage where people say castor oil regrew my hair, right? I don't need minoxidil, I just use castor oil. But it's not true, right? This will improve spontaneously. Stage 2 is where minoxidil is super helpful. So they have thinning there, you put minoxidil there, it wakes up the follicles, you start to get hair restoration, but they have to use it for life. And then stage 3 is when the skin in that area starts to feel smooth, it starts to feel more like the face, and that's where we need Dr. Avram, right? You're gonna send that referral over and say, hey, minoxidil's not working. All of my stage 2 patients wanna be stage 1, right? They come and I say, hey, good news. If we give you minoxidil, it'll grow back. And they say, well, can't I just use castor oil? Then my stage 3 patients come in 10 years after they, need to use minoxidil, and they say, I'm finally ready. And you say, it's too late, right? There's not much that we can do. All right, so here is, again, this rule out CCCA. You guys will know better when you go and see your patients now, right? Because these patients, if you biopsy, there's gonna be some scarring there. Much of it's gonna be perifollicular fibrosis, which we'll get into in my next talk. But I've seen these cases, dermatologists will present them and say, CCCA patients can have excellent outcomes because look at this patient, and it's just traction alopecia. Now, again, if you're aggressive about CCCA and you're treating all those patients with minoxidil anyway, they are gonna have good outcomes, but this is traction alopecia. Now, in the middle there, she's scarred, but this patient, the reason it matters is that this patient, I think, could do well with a hair transplant, whereas a pure CCCA patient, I would not refer for hair transplant. It might look the same, but it's very different. So ask about hairstyling techniques. Ask them if they've ever used dreadlocks. Some of these patients will come to you after they've cut their locks, and you don't realize that they actually just had traction alopecia. So what do I tell patients? Well, one, I know that it's going to be very hard for them to cut their hair at first visit. This is like smoking cessation, right? You don't tell them to quit smoking at visit 1. You just plant the seed. And so I don't tell them to cut the locks, but I say, hey, just so you know, this is a really damaging hairstyle and can get you to permanent hair loss very quickly. Patients will remember that. And I say, first, let's start off by having you decrease how often you retwist your locks. So instead of every 4 weeks, let's try every 8 weeks or every 12 weeks. And usually patients will do it, and you saw that previous patient, that's what she did, and it worked. But if it doesn't work, then you really have to talk to them about cutting it so that they don't get to that end stage, because not everybody's a transplant patient. If you have a ton of hair loss, you may be too far gone. So we have to get them while they still have enough donor tissue and a smaller enough recipient area to benefit from transplant. And all hairstyles are not created equally. Here are some of my least favorite hairstyles. You can take a picture of this on the left. But there are some that are okay in moderation, but really heavily emphasize moderation, right? So if someone's pre-diabetic and they say, hey, look, could I go to McDonald's once a week and get like a 6-piece chicken nugget? Yeah, sure you can, but the diabetic who's on insulin, no, you can't, right? So only some people are gonna be eligible for moderation in the first place, and you have to be careful how you pitch this because you don't want patients to think, okay, I can do large box braids all the time. It's really like a once-a-year thing. There's another consult for CCCA. Again, we're seeing central scalp hair loss, but it doesn't mean that it's CCCA. If you biopsy it, it might say that it's CCCA if you find 4 millimeters of follicular dropout, but this is actually acquired trichorexis nodosa. So this is where a healthy hairstyling practice really comes into play. So this patient, I didn't do anything, right? And at this chief complaint of, I've been treated for 3 years with no improvement, that's not a red flag for CCCA, that's normal, right? It's scarring alopecia, but noticing how much breakage this patient has. This is what hair looks like when you're over-relying on a wig. You're not washing. She has retention hyperkeratosis in the central scalp, so you're not washing your hair, you're not trimming it, you're not conditioning it, and then it breaks. Because remember, that's what it's supposed to do. Another example, this is a young girl who was treated multiple times for tinea capitis because her mom didn't understand why her hair wouldn't grow. It's just breaking. It's very dry, it's very brittle, and you can see just the way the light hits the hair that it's dry. Okay, so remember that chief complaint, my hair won't grow, it continues to break. Another, rule out CCCA. Again, this is not wizardry, right? A lot of our patients don't know how to take care of their hair. There's not a book. It's not like we grew up and like someone wrote a book and passed it down. It's hard to find this information, and they just need guidance. And as dermatologists, we have to know this because we are the ones that are injecting their scalp and subjecting them to unnecessary treatment, right? If you're putting someone on an oral antifungal because you never learned about conditioning the hair, like that's on us, right? It'd be one thing if these patients stayed in salons, but they don't, they come to us, right? So we have to know this just like we have to know that tanning beds are bad, and we have to know that if you have atopic dermatitis, you shouldn't go to Bath & Body Works, you need to be using Eucerin or CeraVe or something that's thicker, right? So we are used to counseling our patients on how to choose products at the grocery store, and we have to do it for hair too. Finally, and I think this is my last slide, curl patterns at risk of acquired trichorexis nodosa. I didn't have the citation here, but this is a study by Lucerne, a group out of France, and they sampled hair shafts from around the world. And these pictures I showed you really are what we see in curl patterns 6 through 8, and that's really going to vary significantly depending on the area of origin, right? And so if you are in an area where you have a lot of African immigrants, New York, Washington, D.C., you really have to be aware that that's gonna, they may have a different hair type than your average African-American patient, right? So just because people are checking off the same box on race, they're very different. In Miami, Florida, a lot of Haitian immigrants will have curl patterns that are very similar to those in West Africa, right? So there's more admixture in the United States, ethnic mixture in the United States among the black population than maybe, say, in Haiti, right? Or maybe even parts of Cuba, right? So just really just keeping that in mind and just understanding that those with really, really, really tightly curled hair are at greatest risk for that breakage. I don't have time to talk about this, but I have written a book on hair care that I'm happy for you guys to pass along to your patients because it's often too much to talk about in a 15-minute session. But this is generally how I tell them to take care of their hair. Washing their hair once a week, deep conditioning with every wash, leave-in conditioner after every wash, followed by an oil or emollient, and that is just a soak and smear. It's just a soak and smear for the hair, okay? So even if you can't remember this, you know what a soak and smear is for the skin, they have to do it for the hair too, okay? And I think that's it. So I'll pass it on.